Hello, everyone, and welcome to the Workplace Suicide Prevention and Postvention Committee's webinar. I'm Dr. Sally Spencer-Thomas. I'm the co-chair of this committee with Dr. Jodi Jacobson-Frey, and together we are supporting this work with a whole host of committee members from around the country. Today, our topic is Interactive Screening Program, or ISP, Intervention for Workplace Suicide Prevention. Our two presenters today. First is Maggie Mortali. She's the Vice President of Programs and Workplace Initiatives for the American Foundation for Suicide Prevention and a longstanding committee member, a pivotal person in the development of the national guidelines for workplace suicide prevention. She also oversees the interactive screening program at AFSP. Our other presenter today is Dr. Jodi Jacobson-Frey from the University of Maryland School of Social Work, co-chair with me for many years on this Workplace Suicide Prevention and Postvention Committee, lending a lot of expertise in research and evaluation and program development, over 25 years of experience in suicide prevention and clinical social work research. This Workplace Suicide Prevention and Postvention work is a collaborative partnership between the American Foundation for Suicide Prevention and United Suicide Survivors International, both nationally based nonprofits in the US focused on workplace suicide prevention. Our national guidelines are really based on these 8 guiding principles, or true north, if you will, that help us guide our decision-making in developing national and work-related suicide prevention initiatives. And so these are some of our core values that you'll be hearing about today as it comes to screening programs at the workplace. And then these are the 9 practices of the national guidelines for workplace suicide prevention, and they're framed really in upstream, midstream, and downstream approaches. And today we'll be talking about screening as it's related to empowering people to really think about mental health issues in a self-care orientation. So that's a midstream, and then helping to connect to them downstream resources. So now I will turn it over to Maggie to go through our next section.
Great. Thank you, Sally. And thank you everyone for joining us here today. So the goals of our presentation are to provide you with an introduction to AFSP's interactive screening program. We'll go through some of the key program aims, how the program works, and really what it seeks to achieve. And then we will review some of our recent research on the program and its use in work settings. So a participant recently wrote on one of our program websites, it was a physician participant, and they wrote that after taking the questionnaire and receiving a personal response from a counselor, they said, "I really appreciate the in-depth, genuine response to my message. It took a lot to bring myself here to send it, so having a real and honest response helps me to understand it's worth reaching out for help." So the program was first developed in 2002. It was originally for college and university counseling centers to use as a method to screen and engage students on campus. And then in 2009, AFSP first implemented the program in a medical school for the first time. And about a year later, they started expanding the implementation of the program from medical students to their residents, and then later faculty, physicians, and medical school staff. And the program is actually still in use today. It's part of one of the research settings that Jodi will be talking about later on, and marked our first workplace implementation of the program. And so to date, we have over 200 settings nationwide, both college and universities, but also workplace settings. And the program has connected over 280,000 people to support services. So every person that submits a screening questionnaire on the program website will receive a personal response from a counselor. And that counselor is within the mental health or the peer support services available to them. On the next slide, I'll talk a little bit more about that process and what that looks like. But essentially, the program takes a bit more of a selective approach to screening because every person that submits a questionnaire is going to get this response. And so Each work setting that's using the program will identify groups of individuals that they want to engage in using this program. So for example, within the healthcare space, it might be a hospital or health system that is using the program to connect with their physicians, or it might be a subset of physicians within a specific area of expertise where they know that that population has high barriers to help seeking and therefore low service utilization within their EAP or other employee wellness benefits. And so by using this online platform, we work to tailor this program for each organization using the program. We allow it to offer complete participant anonymity, but that at the same time, folks can have that personal contact with mental health providers. And the goal there is that they can engage in conversations around help seeking and really work to identify individuals with high barriers to help seeking and then increase service utilization through this program platform. And so the way that this works is AFSP works directly with, in this example, I'm going to talk about an implementation for a healthcare system. And so we'll work directly with the EAP, the Employee Assistance Program, for that healthcare system. We develop their own unique interactive screening program website for their use. And then the program will be made available through the EAP customer portal and promoted to all of the covered employees. And then each new user will access the ISP website. They create their own unique login that allows for their complete total anonymity. They take a screening questionnaire that gets submitted on this dedicated program website. At the same time, EAP counselors are monitoring the website, and when a questionnaire is posted to their attention, they can review and respond personally to the questionnaire. Once that response gets posted, the participant can log in, they review the response, and they are invited to engage in an online dialogue with the counselor all over this website. So that allows for them to maintain that level of anonymity that they had when they first submitted the questionnaire. It allows them to access this program website at any time and reach out to the counselors staffing the program to ask questions. It's an opportunity to learn about available resources and services. For some EAPs, they offer the option of connecting with a counselor over the phone or getting a referral through their referral system. And it's something that they'll always have available to them should they need it. So with that, I'm going to turn it over to Jodi to talk about highlights from her research.
Thanks, Maggie. Great to hear about the updates and what's happening with ISP. And I've been really honored and privileged to be able to work with the American Foundation for Suicide Prevention to look at some of the data that's being collected in a couple research studies. So I'm going to just present some highlights here about some of the work we're doing that we're excited about. It's not yet published, but we're working on that to get that out there and disseminated publicly. So I'll give some sneak peeks today. University of Maryland was, again, very honored to have initial opportunity to look at the workplace data that you heard about, including some of the healthcare sites, but also some other sites. So what we were interested in from a research perspective is how our healthcare employees, and then the second largest group that we had out of the 21 different workplaces that we looked at data for, was law enforcement. And I should just say this is all de-identified data. So the University of Maryland and my team, we didn't have any information about individuals, since ISP is also anonymous, but we also don't know the actual workplaces. So in addition to thinking about how are they using the program, we also know that the counselors, whether they're in an EAP or in a peer program or even a mental health counselors not doing full comprehensive EAP, they're trained to use some different motivational enhancement techniques in their response to ISP users. And we wondered if there were some differences perhaps on using some of those interventions and techniques on help-seeking behavior. So we were able to look at data from 15 different healthcare sites and 4 law enforcement sites. And people who use the ISP have an opportunity to dialogue, as you saw from Maggie's slide here previously, back and forth with counselors, and they can do that as many times as they want. So our team of 5 researchers coded all of this data, thousands of different dialogues, looking for different help-seeking outcomes. You can see here things like requesting a referral or making a commitment to seeking additional or continued treatment. And also when there was back and forth dialogue, we could see if there were changes in ambivalence about seeking treatment and also changes in willingness to accept services. We were very curious about those motivational techniques. So some of the training that counselors are instructed to use or not use, they're asked to ask questions, to express empathy in their response, to use some constructive confrontation, to use persuasion, and to not use diagnostic language or list symptoms. So again, we looked at the healthcare and law enforcement organizations, and we found some pretty interesting early results for the research. So first and foremost, both industries showed that employees who used the ISP that were in higher levels of distress were significantly more likely to engage in dialogue as well as help-seeking outcomes. So just across the board, I think this is a really important public health outcome in the importance of screening and not waiting for folks to call a helpline or a program, but actually getting that information into their emails in different places to encourage them from a broader wellness perspective to do some self-assessment. In healthcare, we found that 84% of the users who had high distress levels actually opened the email, and over 30% dialogued with a counselor. More than half of those that dialogued requested a referral, and 52% of them agreed that or committed that they wanted to have additional services. In law enforcement, we saw very similar high rates, with almost 80% of those in the high distress levels opening their email and over 50% engaging in dialogue, which is really quite high. And 50% of those that were in dialogue requested a referral and expressed this interest in continuing or getting additional treatment. We did see some differences in healthcare. In particular, the ISP users who had access to a full comprehensive employee assistance program, or EAP, actually had significant greater outcomes related to engagement and help-seeking behaviors than those that had an internal mental health counselor without having the other supports that EAPs often offer, as well as that increased confidentiality extension from the actual workplace. In law enforcement, employees who had an EAP were more likely to open the email, but actually those that had a peer program were more likely to report decreased ambivalence over time and wanting more interest in seeking services compared to having a traditional EAP. So differences in models for different employee bases. And then when it got to these motivational techniques, that was really interesting, because in healthcare, we found that when counselors asked questions, it was significantly associated with all 4 of our help-seeking outcomes. But in law enforcement, asking questions was not a significant predictor. And in fact, confronting gently in terms of social norms or different types of myths and behaviors actually led to law enforcement users reporting an improved willingness to seek treatment, where this wasn't the same in healthcare. So it really goes to show us that, a cookie cutter approach to this type of screening and program, one size doesn't fit all for different industries. So Maggie and I wanted to leave you with some concluding thoughts, implications, and next steps, as well as things that you can do. It's important to remember the importance of anonymity in this program. That's kind of been one of the challenges in workplaces, to think about how to provide an anonymous program. We did a qualitative follow-up study with managers using ISP, and that was one of the greatest barriers to overcome in order to bring the program. But ultimately, it was the best part of the program that really led to overall reductions in suicide at some of the different workplaces, and of course, being able to reach folks that weren't reaching out in other ways. The ISP, as you saw, needs to be customized, so really considering how to match the workforce preference to the type of services being offered. And it's important to recognize that the counselor's use of the different techniques vary. And that also has a lot to do with how it's promoted, how we're training, and what are those outcomes we're looking for. As we continue to do more outreach, we need to make sure the directory of resources is up to date and is robust, as well as being culturally relevant and inclusive for where we make referrals. And we should be thinking about how to share the results from the data. So we're in the process, like I mentioned, of writing up these results, as well as some of our qualitative data. And we're actually doing some follow-up studies looking at residents who are using the services, as well as some additional opportunities to follow up with users. So as we leave you today with a little bit about the ISP, we think it's important to assess your programs and not only look at who's utilizing them, but think about who is not utilizing them. Who are the folks that are not calling your EAP or your peer program or not engaging in different ways? And could a screening, be an option that you add to your comprehensive suicide prevention and workplace mental health plans? Are there anonymous options open? And if not, why not? Can you start having conversations about doing things a little bit differently in order to reach greater numbers of people at risk? Do your screening programs connect to the counselors? Sometimes we've got screenings on websites and then someone recognizes they need help and it doesn't actually connect them with a person or a trusted program. So making sure that these screening programs are really fully embedded into your broader workplace programs is a strong recommendation. And we recommend that you take a look as the research continues to come out about ISP and other screening programs to keep updated to see what makes the most sense for your workplace. So we leave you today with a couple resources and references. If you want to learn more about the interactive screening program, there's the website here. And then if you want to follow some of the research that we're doing at University of Maryland, there's a link to my center, the Be Well Center as well. And I'll turn it back over to Sally.
Thank you so much, Jodi and Maggie. As you both know, I'm a huge fan of screening programs, but especially the interactive screening program, the self-empowerment focus, the proactive lens. Just like of other health issues, screening helps us identify things earlier in the process before things become catastrophic. The linkages to the trusted resource, all of that, the wearing down the barriers and the exchange, especially of reluctant help seekers. It's just brilliant. So congratulations, both of you, on this work. And this study is pretty monumental. What a large scale study across industries, baking in other things we know that work, like motivational interviewing. Well done. So for those of you who are new to this conversation, come on over to workplacesuicideprevention.com and take the pledge to make suicide prevention a health and safety priority in your workplace.